Good morning. Today, I would like to speak on cervical dystonia or the different forms of dystonias. This usually presents with a sustained posturing of head to one side, with sometimes with a tremor or a clonic contraction of the neck. So the neck turns to either to one side. Is called torticollis, or maybe lateral collis. It will be shifted to the right or left side, or anteriorly is called anterocollis, or backwards called retrocollis. This is quite common in the population, especially in the middle-aged females. Basically, so two types are there. One is a primary dystonia or primary cervical dystonia, or a secondary dystonia, or the dystonia due to a musculoskeletal or neurological problem. The primary dystonias are quite common. That's what the different forms, like cervical, various forms of cervical dystonia. Sometimes the head can move to either side, as though in different forms of the Bharatanatyam, Mohiniyattam, the head turns to, let's say, it's called a caput, the tortic caput, the lateral caput, the androcaput and retrocaput, depending on which muscles are acting more. Usually in torticollis, the opposite sternocleidomastoid as well as the same side, that splenius capitis, works more. It's a dystonic aberrant or abnormal contraction which would cause pain, swelling, hypertrophy, tremor, or deformities. All right. Though this dystonia or the cervical dystonia may be due to various secondary cause. The secondary forms of dystonia due to various neurodegenerative disorders like Parkinson plus syndrome, Huntington's, or various neurometabolic disorders, Wilson's, hypoparathyroidism, or due to various drugs like neuroleptics or metoclopramide or phenothiazines, or it may be due to various musculoskeletal problem. The musculoskeletal problem may be in the form of the spine problem, like a disc, cervical disc, any infection, abscess in and around the pharynx, larynx, or in the neck or the spine. Sometimes there can be a problem in the brain, like a posterior fossa lesion, photonuclear lesion, or some eye problem like a fourth nerve palsy or oblique palsy. Or sometimes there can be a Sandifer syndrome, wry neck, contractures, or any other musculoskeletal, or any Arnold-Chiari malformations, Klippel anomalies, and many problems in and around the shoulder, neck, posterior fossa, the posterior part of the brain, as well as this spinal cord. This all causes a mechanistic form of a dystonia, where the treatment may not be effective, where we have to undergo various surgical modalities of treatment. So basically the investigations are, the history is the most important thing, because the history will have a sustained contraction of the head to one side with a tremor of head, with pain or spasm or thickening of the muscle, which gets worsened with stress or fatigue. And after the usual blood tests like CBC, ESR, calcium, magnesium, sometimes you have to work for Huntington's, Wilson's, Parkinson plus syndrome, other neurodegenerative or neurometabolic illness. You have to take a good history for any toxins. There may be history of various infection like CJD or encephalitis or meningitis or stroke or something else, when you basically ganglion disorders. These sort of things, that's why we have to evaluate with a MRI or a neuroimaging. Then once you know that it's a dystonia, it's a cervical dystonia, then the treatments are basically two types. One is a conservative, where you do the hypnosis, the relaxation, biofeedback, massaging, stretching, and various forms of physical therapy. Once it fails, then the next option is various medications like benzodiazepine, clonazepam, trihexyphenidyl, tetrabenazine, pimozide, beta blockers, primidone, baclofen, or other anti-epileptic medication. You can just give it a try. If it doesn't work, then the ideal treatment throughout the world start on botulinum toxin. There are various brands available in the world like Botox, Dysport, Xeomin, or Myoblock. Many brands are available. So you can give the botulinum toxin by various means. One is depending on the pain. Suppose there is a more pain here with a tendency for the head to rotate one side. Feel the area where is the maximum pain. Secondly, look for the muscle hypertrophy, because you know that for the torticollis, the ipsilateral, the contralateral sternocleidomastoid as well as the ipsilateral space capitis can give botulinum toxin maybe 50 to 100 units, including both right and left, maybe 60% to the ipsilateral splenius and 40% to the opposite sternocleidomastoid. Or if there is a lateral collis, you can direct to the scalene muscle, the levators. Retrocollis, you have to go to the posterior neck muscles. Anterocollis is quite difficult, but sometimes you can get the upper part of the the sternocleidomastoid. Then we have various caput, retrocaput, anterocaput, torticaput, where you have to give to the rectus capitae, the posterior neck muscle, deep neck muscles, where you have to use a ultrasound guided injection. And even for this thing we can use a EMG guided. So we can have a multimodal, we can have a local pain related muscle hypertrophy, then the anatomy, ultrasound, or by EMG, or maybe we have to use a EMG with the ultrasound, and you follow the pain and the different various forms. So that's how you treat botulinum with the botulinum toxin injection with cervical dystonia. So once maybe there is some condition called resistance or antibody formation for botulinum toxin. In those cases, or if the drug is not effective, especially if the patient has got a segmental dystonia or hemidystonia or a generalized dystonia, or if there is a secondary cause like Wilson's or Huntington's or Parkinson plus or Parkinsonism, this may not be effective. In those cases, you may have to go further, like you may have to do a deep brain stimulation or a thalamotomy, a rhizotomy, a myomectomy, or a neurectomy. Sometimes there can be a multimodal method has to be implemented. So this is in short regarding cervical dystonia. You should know that it's quite common in the population. And there's one more thing, around 20 to 30% person may have a remission. They may become normal in between. It doesn't mean that they'll be fully cured, but sometimes it can remit for some time, for some months or years. Okay, and for some people they use some trick called a sensory tricks, because if the head goes to one side, they can use a finger or some touching the cheek or the jaws or something, which would prevent the tonic contraction. So I would like to stop you by telling that it's quite common, the treatment is quite effective. Botulinum toxin is a drug of choice, but of course you should use the other medication as well, but you should be careful when you use this the pimozide and the tetrabenazine. Sometimes this causes a QT prolongation and the complication. Okay, thank you very much.